one of the things I'm keen to do is I'm beginning to get into social media. I'm very into LinkedIn, but I'm only beginning to get into Twitter. And I have, I think, what's called Twitter envy, which is when somebody has much more followers than me. So one of my friends is up around 2,000 and I'm only at about 800. So I'm feeling that I know it's all about quality and not quantity, but even still, if anybody likes what they're hearing and wants to follow me on Twitter, that would be a nice outcome for me as well. So there's my Twitter handle, as I believe it's called. And without further ado, I will jump into the slides. So 4 points I'm going to touch on today. And again, by all means, I think, ask any questions, type them in, and they might come up to me. I think I might be able to see them as well. So I think you're all on mute, but indeed, please just type something up and I'll try and answer it in the middle of my presentation. As Beverley said, 4 learning topics. What do we mean by information for patients? And for all of you that know the way the NHS works, we have something called the Patient Information Advisory Group. And I got very excited about this and I thought, at last, there's a big fancy advisory group dedicated to information for patients. But many of you will know that's actually an information governance group, and it's concerned with information about patients. And that's not what today is about. This is very much focused on how we live the dream and actually move from that rhetoric to reality of putting patients at the centre of their own care and supporting them to do that. I'll talk a little bit about how we personalise experience around information provision, because as we see many times where information is given, and sometimes that's sadly too rare, it's not necessarily personalised. But if we were to think of information as a therapy, and I'll make the case for that, really we should be tailoring information to the recipient. I'm a pharmacist by background, and I wouldn't dispense or endorse a prescription where I didn't really, at least in a hospital setting, understand the body mass index, the renal function, etc., of a patient. Why should I just give out information that seems to fit one person, irrespective of their age, their literacy, etc.? A particular bugbear for me is how we integrate information into healthcare delivery at the moment. With the exception of some private hospitals that I've seen, there really isn't much of an audit trail, excluding informed consent, where we see what information has been actually given to patients and what they've understood, and I think that's a concern. And if I were wearing my lobbying hat, I would say that that's potentially negligent, and we can maybe touch on that later. And then lastly, I will touch on what is really needed for all of this, which is build it, they will come. I'm not so sure they are. How do we change, and who needs to change in terms of culture? So without further ado, and if there's no questions popping up, I will jump into the information type side of things. So I think first and foremost, when I talk about information, I think it's really important to talk about information and support. So I don't see leaflets, I don't see websites, CDs, whatever we're doing as information in isolation. In fact, the evidence suggests that information provided in isolation does not elicit behaviour change. And I think we need to be very concerned. I remember speaking to, and I won't mention them, but a particular very large and well-known Canadian organisation who said, we're going to be producing a huge web portal for seniors, and it's going to have lots of information and lots of ways to interact. And I said, that's great. To what effect? And he went, what do you mean to what effect? I said, well, what outcomes are you hoping to achieve? And he said, well, we're just building a big website. I said, but okay, that's nice, but is it purely to inform, or is it to elicit some sort of behaviour change amongst clinicians, amongst managers, amongst patients, carers? Well, we've never thought about that. So we very much at the Patient Information Forum, which I'm a non-exec director of, spend a couple of days a month doing that, and at Monmouth Partners, and indeed all of us, I think, should begin to see information as a mechanism by which to elicit behaviour change, not just to inform. So when I talk about information, it's information and support. In terms of what types there are, broadly speaking, there are 3 types. There's well-being and lifestyle information, so looking at diet and activity, etc. And most of us know this information about eating 5 a day, now excluding juices from that, or potentially excluding juices, that we should be doing 30 minutes of activity, and that doesn't need to necessarily mean joining a gym. That we should be flossing our teeth every day. I don't know how many people floss their teeth every day. I certainly don't. So information doesn't necessarily mean behaviour change. So there's lots of things we know, but we don't necessarily do them. In terms of general clinical information, people out there are told you have pulmonary hypertension, you have diabetes, you have multiple sclerosis, your diagnosis, your prognosis, your treatment, and I'll come on to talking about care plans and the lack thereof later on. There's information which is much deeper to facilitate what we call evidence-based patient choice, and that's the whole movement around shared clinical decision-making, where patient preference is particularly important, especially where the outcomes, broadly speaking, are the same, and I'll give you probably one case study on that. And then lastly, increasingly so, when we talk about patient choice, it tends to be in a political sense of being able to choose which particular hospital or which service you want to go to, and I'll touch a little bit on that as well. So that's the broad overview of the 4 types. Just literally fly through some quick examples here. Obviously, we've got government portals, and earlier this week I was doing an international seminar and was quite surprised. America's got a government portal, Canada's got one, but amongst the French and the Spanish and the Greeks, the Nordics, etc., who were also present at that meeting, and again, I'm not saying this is indicative or true, but at least the people of that meeting seemed to suggest there weren't necessarily government portals like we have in England as NHS Choices, that they have up in Scotland as NHS Inform, and they have in Wales as NHS Direct Wales, providing lots of relatively good content online for patients. So again, we should pat ourselves on our back for the fact that we are doing something at that level to give people a destination. And it is claimed that NHS Choices is growing monthly and has something like 40 million unique users going on to that. There's other more subtle and more behavioural interventions. So questions to ask were developed, I think it was way back in 2007. And again, the idea being, when I go to see my accountant and I get a 15-minute appointment, I go prepared. How do we encourage our patients and their carers to begin to think about, well, hold on a minute, before you go to this appointment, why don't you write questions down that you'd want to be asked? Because sometimes in the emotional side of the moment, you forget. Take down what medicine, bring down the list of the medicines that you're on, etc., etc. One of the key points is don't be afraid to ask if you don't understand something. And again, thinking about our own behaviours as clinicians, as patients, as carers, do we really have the courage to say, I'm really sorry, doc, nurse, pharmacist, social worker, I don't really understand that. Can you say that again? And that takes a certain amount of skill, and we'll touch on the idea of how we encourage patients and carers to ask these questions and not to be embarrassed about not knowing. And then obviously there's the stuff about, before you leave your appointment, make sure you know what's going on. And, a personal anecdote, which my mum has allowed me to share. A couple of weeks ago, she left her cardiac consultant who said, next time you see me, you're going to come for an angio. And she didn't know what the last part of that was. Was it an angiogram or was it an angioplasty? And I said, Mum, with respect, they're hugely different interventions. What information sheet did they give you? Well, they haven't given me anything, Mark. And I was like, what do you mean? You no one's told you anything? No one's written it down? Nope, don't know what I'm going for. And to me, that is negligent. To not inform a patient what they're doing and what they're going to have is just, to me, crazy. So, an 80-year-old lady who knows it's something to do with her heart, but doesn't know whether it's a major operation or whether it's actually an investigation, a diagnostic, I think is sadly lacking. I said earlier I would talk a little bit about shared decision making, and those ladies amongst us don't need to worry about such things in the future, but us men sadly do. There's issues about an enlarged prostate, and people often say to me, let patients decide if they want to let the doctor make decisions. That's fine too. And I push back a little bit on that, saying we're a very rights driven NHS system, and our UK generally, and I sometimes think we need to begin to push patients and citizens to take a little bit more responsibility, and especially in areas where doctors shouldn't or can't make the decision for you or for the person you care for. And so I have particular experience where my father had this particular condition, and my dad said, the doctor can decide. Now, first of all, his GP was a lady, and secondly, I said, Dad, even if it was a man, they can't make the decisions as we've got in front of here. The idea of sexual impotence, the idea of incontinence, either single or double incontinence is a very personal issue, and you need to decide where these things are. Someone can't make that decision for you. So I think I'm using an extreme example to make a point, but I think there are times where we need to begin to get medics to turn around and say, I can't make the decision for you. And I think there are very much times where we need to say to patients, you need to be encouraged to take responsibility and, dare I say, step up to the plate and not just hide behind, no, I don't want to make that decision, you do it for me. I'm sure that will open a debate and discussion as to where we are in that continuum, but again, I'm taking an extreme example just to show that. Many of you will have come across the concept of self-management, and there are many courses out there in structured patient education. I'll come on later to the issue that, to be honest, it's much talked about, but the recent State of the Nation study from Diabetes UK made the scary statistic that 80% of all amputations caused by diabetes are preventable. How are they preventable? By good education. And only 1.6% of the eligible population for structured patient education actually get those courses. So again, in my earlier point about negligence, if we know that information can actually prevent amputations, and we're not giving information and support to people to be able to make those right decisions and support them in lifestyle change, are we being negligent? So again, making an extreme point, but I think sometimes we need to swing to one side in order to bring us back to a happy medium. Most of us, and I say this having not had a mobile phone for the first few years that they came out, but sitting with my iPhone beside me, are pretty familiar with technology. But it's not just apps, as we can see from the choices apps library that's online, but there's also touchscreen kiosks. There's bedside kiosks that many, if not most, hospitals have now, and so really technology is surrounding us in many ways now. And I haven't gone into wearables at the moment. I think sort of the jury is still out, and again, maybe very much anecdotal experiences. I had a Fitbit for a month and then got a bit too bored of it. So at least in personal experience, they're not quite there yet. A show of hands is difficult on a webinar, but I'd be interested, if there indeed are anybody out there who has got access to their records. Something that the Patient Forum, Information Forum came out with a couple of years ago now was just, there's all this talk of records access. It's now mandated as of this month or last month in April that patients with long-term conditions should have access to their records. And I think we're still pretty low down in terms of percentage access. My own GP surgery has an EMIS system. I could get access in theory, today, but they haven't yet set the systems up to do that. So again, there's the issue about the technology is there, the ability is there. It's the culture change that is perhaps holding us back. And the evidence does suggest where you have companies and organizations like Kaiser Permanente, where they have 4 million patients accessing their records, that these things do improve outcomes, they improve morale, both of patients and indeed of their clinicians. And a gentleman not too far from me up here called Dr. Amir Hanan, you'll see at number 53, page 53, the Thornley Medical Practice, is doing some great stuff and has about 1,800 patients, I believe, now online. And he runs the ex-shipment practice. So in order to reverse some of those negative issues around transparency, he really wanted to get many of his patients online and has succeeded with that. And he says very clearly he's a better doctor and his patients are weller because of it. So it's not just nice to have, but perhaps we're heading to a must-to-have or a must-have. And there's different ways, as we know, of presenting information. This I love from UCB Pharmaceuticals, who do work in the epilepsy side of things, have a board game for children. So again, thinking innovatively, it's not just one size fits all, but we need to think about our audience, the messages we're trying to get across, and communicate them with them in innovative and hopefully outcome measured ways. I think, unless we lived in a cave, I think we'll all be familiar, as mentioned earlier, with the idea of social media. And I was doing some work earlier in the week on this area of pulmonary arterial hypertension, PAH. There's about 7,500 patients in the UK with this condition. It's a rare disease. Health Unlocked, which is another Patients Like Me type website, allows patients with similar conditions to talk about issues that they have. There's 7 centres in the UK. They're quite spread out. So it gives people an opportunity where they have access to begin to ask questions online and to get peer support in between their visits, etc., etc. And I'd be interested in how many people out there are familiar with Health Talk Online. It used to be called DIPEX, based in Oxford, have done not every condition, but several conditions in an evidence-based way, presenting patients with other people's views on all the different conditions and treatments that are applicable to them. So going back to prostate enlargement, you have surgical interventions, you have drug interventions, or indeed you can have watchful waiting, which is doing nothing and seeing if you can cope with the symptoms. And each of those different areas then have subsets beneath them in terms of which drug or which surgery you'd like to look at. And many of these are actually presented within Health Talk Online, so you can begin to hear people actually expressing what it's been like to go through a particular avenue. So I think really some key points I'd like to bring up is we need to talk about, quality of information. I haven't touched in detail on the information standard, which is the English system for, in inverted commas, kite marking or quality assessing information. PIF, the Patient Information Forum, also has a sounding board where you can send information as opposed to your process in, and experts have a look at that. One size does not fit all, and as a pharmacist I sometimes get saddened when I see patient information leaflets and medicines packaging, which, less litigious as they've been, but are still very much a one-size-fit-all approach. And when I see a 3-year-old baby, or child, and a 30-year-old and an 80-year-old all getting the same package insert, I think to myself, we're missing an opportunity here. The dosing is very different from them, the medicine is very different, but the information seems to stay static. And to those of you out there, and I'm sure none of the audience say, children are not just little adults, as we all know. So you need to tailor information, and we produced a guide on how to do that. So again, we need to think about how to tailor information. As I mentioned at the beginning of the webinar, what are we trying to do with the information and the support around that? Are we trying to get them to act? Are we trying to get them to go for screening? Are we trying to get better lifestyle change, etc., etc.? And I think what we might want to begin to do is, rather than call leaflets and websites and everything we've seen information, perhaps we need to move towards the concept of education, because then, as with this webinar, we begin to have learning objectives, we begin to look at measurables. It's not just a passive provision of a product, but actually measuring its impact. I haven't touched on it much today, but one of the considerations, I think, for us is also about how we design information. And there's a couple of examples I often use about heart tests and various tests that we use, where we give patients some sort of horrible scribbled or typed up paper that really makes very little sense. And there's great examples which anyone interested can get in touch about, where information design can really make information come alive and make it personalised. As Anna said already, think of all the things we do, how was the information delivered, etc., etc. We need to look at evaluating the impact. Just a little bit of discussion around how to make information personal, and we've touched a little bit on that. And thank you to NHS Scotland for some of these great cartoons that you'll see popping up. Yeah, I'm a Scot, so there's obviously affinity up north, but I also particularly like some of the cartoons that have come up from the work they've been doing up there. So just how do we make it personal? Well, a number of ways to do that. I think first and foremost is the need for us to recognise that as clinicians, as managers, as improvement professionals, we often see things as we are and not as they are. I think we potentially are slightly better at it. We're on webinars like this. We're trying to change our perspectives. We're trying to think differently. But often we'll start at the X side of this diagram on the right-hand side as the hard medical side. And we might think, in my case, of a medicine as a pharmacist, and our whole focus is on that medicine, the information leaflet, the side effects, the dosing, the storage, the packaging, etc., etc. And perhaps forget that that's part of a treatment schedule or a broader treatment, which is part of a condition, which a patient has, and there may be many conditions. And if we're lucky, we get to the patient side, but we often forget about the person. And I'll touch on that a little bit more in the next slide. Whereas when we've done work with patients, and we've worked with NHS England on the medicines optimisation strategy, we've worked with them on the innovation, health and wealth, person-centred care is beginning to take it the other way round. And when I'm running workshops and seminars face-to-face, I'll often ask the audience, how many people do we have in the room? And obviously everyone puts their hands up. Well, most people put their hands up if they're listening. And then I say, and how many patients do we have in the room? And people put their hands down. And I'm saying, well, hold on a minute. We may not be a patient now, but you're registered with a GP, because 99.9% of people are. So in some aspect, we're a patient. But we need to think a lot more, I'd suggest, about the soft and the social side. And in these workshops, going back to them that we've run, patients often talk about, the medical language, the healthcare language. And I remember one particular comment stood out for me and said, this is the language of medicines. This is not the language that people use. So I think we just need to be very careful and take a step back and think as people first, not just as product. And I think this is well described, and again, forgive me for the focus on medicines, but it is my professional background, and we spend £14.4 billion out of the £109 billion in NHS England on that. So it is, by all, with the exception of wages, is the biggest intervention, and yet, broadly speaking, we have a 50% failure rate for patients to take medicines as prescribed. And I think one of the reasons perhaps for that is that we're not particularly clear on a number of different things. And we don't think of medicines in the right context. Now, those of you working in diabetes care will be familiar with this, a prescription for insulation. No, a prescription for, I'm thinking of insulation because I'm getting cold down in the garden, but don't worry. One meaning of the word pharmaco, which is the Greek origin of the word pharmaceutical, pharmacology, etc., is that it's a medicine or a drug. And we'll be familiar with the storage, the administration, the prescribing of insulin. One of the things I often say to caregivers who are aware of insulin is when they're prescribed it, administered it, dispensed it, whatever it may be, do they think about this? Do they think about a recipient who has to stick on once-a-day insulin 350 needles into themselves? That's the caregiving side of things. Writing a prescription for insulin, dare I say, is quite easy, but that idea of thinking, well, no wonder perhaps 50% of patients don't take medicines, is I don't think we consider enough the quality of life or the detraction of the quality of life by simply giving a pill. You must remember, and I speak from experience, having 2 long-term conditions, that every time I take my pill, it reminds me that I am mortal. It reminds me that I am broken, that something is wrong with me, and I need information and support to encourage me as to why I should be taking that medicine, which I'll touch on in the next slide. But the other side of the word pharmaco, because it has 2 meanings, is also the word poison. So pharmaco in its Greek origins literally means a medicine or a poison. And my suggestion is that to us who are involved in medicines, either as pharmaceutical companies, and as caregivers and as clinicians, is that going back to the information and support, unless we give information and support, we're going to think of medicines as poisons, not as medicines. And so rather than think of it as, oh, we're miracle cures, they're fantastic products, perhaps if we thought of them as poisons, that only with the addition of information and support to patients became medicines, we'd be in a better position to support patients who would then, if they so desired, actually take them as directed. And I think this touches on the idea of a personalised health service. Going back to the experience that we have of our patients, we normally know their past medical history and their current medication. In many cases, we'll know their ethnicity and sometimes know their communication preferences. But where I think we begin to really fall down, and I bemoan the loss of the family doctor who obviously just inherently knew this through the relationships that they have, we don't really know whether somebody considers, for example, diabetes as a touch of sugar or a life-threatening disease. We don't know in terms of their medicine beliefs, and going back to the earlier slide, whether they are indeed a miracle cure or a poison. And in terms of health literacy, which in itself is a whole discussion, which is independent of literacy and numeracy levels, so we can have PhD students who are highly health illiterate. We need to understand whether patients understand the health system that they're operating in, that they're being asked to navigate through, and sadly, as we see, it's increasing complexity. And even if we knew all 3 of those, are they motivated to do anything about it, especially in the context of moving beyond health? So we know about the social determinants of healthcare. We know that employability, we know that income, we know that a variety of different determinants make up people's health. And as someone said to me, why would someone be worried about their HbA1c level when, you know, their partner is trying to kill them, or their children are on illicit drugs, or whatever it may be? So again, we often get very focused on that X in an earlier slide and forget about the person side, that there may indeed be other bigger things or bigger fish to fry. Just a few more slides left. In terms of how we get motivation, that middle yellow box, there's some work being done by Professor Hibbard in Oregon and America around patient activation, and we talk about these 4 levels. Starting with level 1, where really you say, hold on a minute, I don't get involved, I'm quite passive, my doctor's in charge, right up to level 4, where it's very much around, I'm in charge, I take care of stuff, I'll navigate the system, I'll make demands, I'll keep pushing, as funnily enough we do in many other areas, in hospitality, in retail, in travel. We are quite demanding, and it's often interesting to see level 4 consumers down at level 1 in healthcare, and that's partly because we don't want to be consumers, we don't want the long-term condition, but it's also partly because of the culture that we find ourselves in, both in terms of clinicians and indeed as patients. And an important point, given the £30 billion deficit we keep hearing about, is that actually activated patients are cheaper, broadly speaking. So work that's been done by KPMG across several countries has shown that literally a level 4 patient who's very activated compared to a level 1 patient can make around 20% of savings. And over 110 billion equates roughly to 15–20 billion. So that's quite a big saving to be made, again, in terms of fully engaging the patients out there. And as I mentioned earlier, you know, I'll say hello to Judith. Hello, Judith. Judith came up with this work, and interestingly enough, in the second bullet, showed that it's not just about the middle class, intelligent, educated that can do this, but actually even sicker patients can actually also begin to, through activation, make contributions to their own care and to the bigger efficacy of the system. So my big issue really at the moment is we can produce great information, build it, they will come, but my last little few slides will focus on how we integrate that into healthcare delivery. And many of you will be aware of the map of medicine, which sadly has been taken off NHS Choices. It used to be available to patients, but no longer is. And this is quite a complicated pathway for hypertension. But I think what we need to begin to do is to look at points along this pathway where information should be provided to patients. And going back to my mother's sad story, you know, to not know whether it's an angiogram, angioplasty, whatever, to me shows a lack of sensitivity, a lack of import as applied to your patient. And again, to be extreme, could be perceived perhaps by some as negligent by not telling your patient what's indeed supposed to be happening to them. Information prescriptions have been a way of integrating information into healthcare pathways. There was lots of work done a few years ago. It's gone very quiet, and cancer has kept the ball rolling, but sadly in other areas, with the exception of NHS Choices, there's not really much happening out there, and I find that sad and an upsetting thing, and I do think we need to go back to the idea of integrating information into the system. Care planning is one way to do that, and with my 2 long-term conditions, I have a care plan for neither, and I think that's sad, and I will come on later to a statistic that is even more saddening. But it's not just the care plan that's needed, but actually the process of care planning, where we sit with patients and their carers and talk about what are your goals, where do you want to get to? And again, how can patients be involved in healthcare if they don't know what their destination is? So just how do we change culture? Well, I'm a clinician, and I'm sure there are clinicians on the calls, and I'm not clinician bashing. We want to do well, but we're often taught to care for or to deliver care to patients. We're not so great at doing care with patients, and that's part of the culture. It's part of how we've been educated. We don't do much on the asset model of healthcare. We look at what patients can bring and help themselves and others. We look at the deficit model. Oh, you're broken, and I'll try to fix you. And I'm not saying that we throw that model out, but we do need to look at what patients can also do for themselves. So we need to change health education. We need to change some of those behaviours. And as the Lancet said 10 years ago now, we do need better information. We need to work in health literacy at school level, but we also need to really look at other health professionals making sure and talking to patients, have you understood what's going on in a non-patronising, in a non-threatening way? And there are many feedback mechanisms and ways to do that. I think our friends who are commissioners need to begin to look at information, self-care and patient education as first-line therapy. And again, the evidence overwhelmingly shows that those patients who've been informed and supported utilise services more appropriately. So again, it makes cost sense as well. And some work we've just come out with is at PIF is the idea of is knowledge power, and what's coming out is that despite all the rhetoric around patients at the centre and no decision about me without me, there are still huge gaps in terms of providing information for patients and helping them to make decisions for themselves. So I think we need to wake our commissioners up. The providers know this better, but our commissioners I don't see yet. I'm happy to be wrong, but I don't see lots of commissioners yet rushing out to get into structured patient education and to start commissioning some of this stuff. And last but not least, we need to increase expectations by patients themselves. As I mentioned earlier, we surveyed, the government surveyed 1 million, DH surveyed, or CQC I think actually, surveyed 1 million patients, nearly 1 million patients, I think it was 946,000 patients, and 64% of them said, oh, we're as involved in healthcare as we want to be. The issue I have is that when you then ask them, well, how many of you have a care plan, which ultimately is getting from A to B, or to Z, if you're American, but i.e. what's your journey, only 3% of them actually had a care plan. So my challenge is, when asked a subjective measure, how do you feel involved, 64% say we are, but an objective measure, show me an evidence, an object of your involvement, only 3% have it. I'm wearing my campaigning hat. My job, I feel, and our job perhaps for all of us, is to reverse those figures. We really want, 64% of people to have a care plan, but for 3% of them to say we're as involved as we can. Because, as I've hopefully shown, it makes financial sense, it makes cultural sense. The clinicians I talk to who've embraced this new model, like Amir Hanan and Brian Fisher and various other people, are, dare I say, happier, less stressed individuals in the job that they're doing. So really, in summary, what we're trying to do is move patients from being passive recipients to active, participants in healthcare, about understanding their behaviours, moving them into making choices, as we do in so many other areas of our life, but we tend to stand back in healthcare. And really what we need to be doing is to think experience, not process, because again, if I were to redraw this diagram as it is just now, I think I would replace person with the term NHS, and I would write people in terms of the services. It's people at the moment that seem to run around the NHS. It's not the NHS that runs around people.